Morning everyone. We are going to start with another case scenario. It is a surgery topic. It is a question, it is a case scenario, it's an MCQ. There are some topics under which comes as short notes and important Viva questions too. So we're going to talk about a case of polytrauma. So basically let me discuss the question with you. First is a 36-year-old male, okay, presents to the ER. Presents to the ER. Following an RTA. There is road traffic accident. Now, the patient presents with pain abdomen. So, pain abdomen is present. Fine, very good. Along with pain abdomen, the patient has a patterned abrasion. This is how the question comes. Patterned abrasion over the stomach area. It is over the abdomen, just straight over the abdomen. Fine. The vitals are as follows. Now, in MB, they're giving vitals stable or unstable, or they may not say anything about the vitals. They may say patient undergo road traffic accident, bike handle injury. Anyways, they might give, and there is an aberration, and you can approach it from there. So the vitals are either they may give stable vitals or they may give unstable vitals. This is the thing you need to divide in the beginning. If they give unstable vitals, so in this case, the patient suppose has a pulse of 114 per minute, which is feeble. Clear? The BP is 80/60, which is hypotensive. The serum lactate, now, it's 8.9. It's quite high. So patient is in acidosis. Base deficit is high. Extremities are cool. So extremities are cool, and you should realize that the PT is more than 20. Just imagine. So basically, the patient is bleeding, the patient is in acidosis, the patient has extremities in shock, the patient has a feeble pulse and is hypotensive. And if stable, these following parameters would be normal in stable cases. Clear? Okay, this is basic stuff. Now, suppose we are going to how to approach this patient. This is the thing which they give you. The most common mistake people do is say fast or fast. No, this is not the first thing you are going to do. A patient is unstable, he or she is calm. You are going to follow the trauma protocol of ATLS. What do? First, you do two things together. You do resuscitation and you do patient survey. That is patient's primary survey. Both of them, you do it together. Not one after the other. So you have to do this simultaneously. Clear? Resuscitation. What kind of resuscitation do you do in case of unstable patients? Very important question, short note, MCQ. Viva, damage control resuscitation. We will talk about the steps of that in a while, so that a short note or a Viva question can be answered. And in primary survey, everyone knows you stabilize the C-spine. You rule out C-spine injury, you stabilize the C-spine. If there is a chance of C-spine injury and all that, you send for the scans for the C-spine. So you stabilize the C-spine and you secure airway. This is the first thing you're going to do. Definitely. Leave alone everything else. First, you're going to do this. This is what you are going to do. The primary survey, you need to do this. That is A, B, C, D, E. So that is the airway, spine, airway, breathing, circulation, disability, and exposure and environment. This is the thing you're going to do. So all has to be done simultaneously. So A followed by B followed by C followed by D. You have to start the assessment. So you have started your damage control resuscitation and you are surveying the patient for this. Now, do not waste time for survey and keep the patient bleeding or with an unresuscitated and unstable. You may lose the patient in that case. So what is this DCR? There are 5 steps of DCR. Please remember there are 5 steps of DCR. 5 golden steps. Number 1 is limited use of crystalloid. Previously, it was believed that you give more and more of crystalloid to combat the amount of bleeding which is present. But you won't do that anymore. If you do that, if you give, overzealous amount of fluid, what will happen? There will be dilutional coagulopathy, and the patient will again, it will harm the patient. You may lose the patient. So you won't do that. So you give limited use of crystalloids. Now up to 2 liter. How much up to 2 liter you are giving? They say that, okay, 500 ml generally, maximum up to 1000 ml, that is 1 liter, you can give it as bolus. The rest 1.5 liters or 1 liter, if you have given 1 liter previously, you're going to give it as infusion slowly. Clear? Now, this is the first step you're going to do. What crystalloid you're going to do? 0.9% sodium chloride. Now, some of them, I don't know why, says Ringer lactate. There is Ringer lactate, Hartmann solution has no role over here. Patient is already in lactate, as lactate is high. You are not going to add to it by giving Ringer lactate. So please refrain from giving Ringer lactate, even though it is a crystalloid. So give all ones which are like 0.9% sodium chloride. No dextrose, no DNS, nothing. Now, next is, you are going to use of what? Patient is bleeding internally, maybe liver trauma, splenic trauma, renal trauma, pancreatic injury, intestinal injury. I don't know. Any bleeding is happening inside. So there is hemoperitoneum. There is patient is in shock. You have seen this. So you're giving use of blood and blood products. Now, which one do you prefer? Obviously, we'll prefer blood products over whole blood. Again, because blood products like the cryoprecipitate, because it has the coagulation factors, we need that for the bleeding to stop, rather than giving excess amount of the water which is present in the blood. Now, next is, you just imagine when you are doing damage control resuscitation, you are giving crystalloids. You are continuously giving crystalloids, and you are still not being able to raise the BP to 120/80, or the mean arterial pressure to normal. Don't worry about it. You may keep it maybe at a level of 100/70 or 100/60. That is known as permissive hypotension. And that is what is important to know. You have to give permissive, so that mean arterial pressure is nearly about 65 to 70 millimeter of mercury. It's around this much you have to maintain. After this permissive hypotension, you are going to do something which is brave, that is trial of hypertonic saline. Now, hypertonic saline is something which, 3% sodium chloride you are giving this. You have to give it in such a way, you cannot give it overzealously, otherwise central point myoanalysis. If you increase more than 12 millicurrent per day, so you cannot do that in 12 hours. So you cannot do that. So you have to give, slowly, and you have to give this trial of hypertonic saline, because it will correct the fluid shifts which is happening because of the shock. Now, use of cryoprecipitate, please use it if it is required, cryoprecipitate if required, because it has the coagulation factors. Now, next is, when you are giving, so you've understood the 5 points. Adding to this, you're going to write about, this will give you, suppose this is a 4-mark question, this will give you 2.5. When you write the next thing, it will immediately give it +1 if you write the next part, that is dynamic fluid response. What is this theory of dynamic fluid response theory? It's very important to know. Suppose you are giving a case, you are giving fluid. Suppose you are giving fluid for correction. For damage control resuscitation, you are giving fluid. So you are giving crystalloid. First, you give 500 ml bolus. And then you monitor the patient's condition. You see that the patient's condition improves. Then you will, and improves. And if the patient improves, no improves. If the patient doesn't improve, then no improvement, then definitely he or she is something who is a non-responder, not responding. 500 say it didn't respond. So 2 liters say it won't. So improves, no, not improves. If not improves, then it is non-responder. What do? You plan for urgent blood transfusion, because fluid and blood is not the same thing. You need blood. If you push in distilled water or normal saline so much, what will happen? You are going to dilute the blood. So you have to give blood eventually. So if That is the best, but you try with fluid. So improves if the patient improves. Now, is the improvement sustained for more than 15 minutes? Then, if it is yes, then they are responders, and you are going to treat them by continuing the resuscitation. So you will continue resuscitation. Clear? Now, suppose the person after 15 minutes there is no, that means it is not sustained, the vitals. So it means he responded, but now after 15 minutes he is not responding. So he is a transient responder. When he or she is a transient responder, give a second bolus of 500 ml of 0.9% normal saline. If response and sustained, continue resuscitation. No response or again a transient response, then you are going to, just the one which you are doing over here, you are going to plan for blood transfusion. Clear? Now this is the part where Viva is asked. This is the part where MCQs are given. This is the part which confuses people more and more. Why? Because transient responder is something people don't understand. This was what about damage control resuscitation short note. This theory is dynamic fluid response theory. So either you can see that either the improvement is like this, the vitals are like this, and then it became stable, or the vitals never rose only, it fails to rise, or they rose, they became stable, and then they start dropping. So you give the second bolus, again they rise, again they become stable, again start dropping. Or what it happens, it doesn't even rise anymore. So in that case, you're going to give blood transfusion. Okay, clear. Next theory is like, since the patient is in shock, we are approaching this. You have to categorize the shock. In an answer, you have to write the grades of the shock. Let's talk about the grades of the shock. 1, 2, 3, 4. You all know 1 and 3 and 4 you are going to do for blood transfusion. You've read this. 1 and 2 you only continue with resuscitation. What are the parameters? Systolic blood pressure, okay. Then respiratory rate, fine. Mean arterial pressure, good. Base deficit, okay. Base deficit. Then pH, okay. Then percentage blood loss. I'm writing that as last purposely because everyone knows that. And the amount of blood loss. And I think I've missed one or two. Yes, urine output definitely, and the heart rate. Yes, heart rate. So these are the things which have to be seen. So a lot of things has to be seen. So if systolic blood pressure, how do you understand that normal hai? Normal, decrease, makes sense. Mean arterial pressure, normal, decrease, further decrease. Okay, this is important. Mean arterial pressure into, and this is a question again. Okay, respiratory rate less than 15 to 30. It's like, a poem, 30 to 40 and then more than equals to 35. That is persistently high above 35. Base deficit, okay, less than 4 to 8, 8 to 12, more than 12, milliequivalent per liter. Clear? Okay, pH. 7.1, 7.2, 7.3, 7.3 and above. So, okay, less than again 7.45. So, that's saying. Percentage blood loss, that's excellent. More than 40% blood loss, 30 to 40% blood loss, 15 to 30% blood loss, and less than 15% blood loss. Fine. Okay. Next is the amount of blood loss. What is the amount of blood loss? Okay, 750 ml, it's like 750 to 1000, 1.5 liters, 1.5 to 2 liters and more than 2 liters. heart rate. Very interesting. Heart rate would be less than 100, more than 100, more than 120, more than 140. Wow. So these are the parameters. So what are the parameters which we were given? Let us see. Let us go back. We were given that the heart rate was 114. Very good. The lactate was 8.9. That is the base deficit being 8.9. We were given a blood pressure of 80/60 and PT and all that. So these are the things we are given. Only these three things we were given. So blood pressure is 114, means more than 100. So definitely it falls under category 2. 8 to 9 lactate is definitely in category 3. 8.9, sorry. 80/60. See the systolic, it is how much? It is very much decreased. It is very much decreased. So again, it is again category 3 going on to category 4. So if you see this and if you calculate the mean arterial pressure, you know how to calculate. So I'm not going. That is the diastolic blood pressure plus 1/3 of systolic blood pressure minus diastolic blood pressure. So you calculate it. Again, it is going to come to a category 3. So we category 3 going into category, very borderline it will come. So we are seeing that one is in category 2, 2 are in category 3, and one is almost in category 4. So 2 and 4. So basically we can say that the patient is actually either category 3 or category 4 now. So that means we require blood transfusion. That means he is very unstable. So basically if we have to run, you will mark that category 3 only, because maximum of them are matching to it. So blood transfusion is required. So this is what we learn as a part of your damage control resuscitation in this case. Now, the next approach is, suppose this same patient, let me continue. Now we are going to, this was how you are going to assess the patient. Now the assessment and everything is done. You are going to understand, you are going to see how we treat the patient. See, the patient is, limbs are getting cold. So the patient is in hypothermia. The patient is having blood loss. So, and also acidosis is happening because lactic acidosis is there. And the patient has, giving blood and blood loss is happening. So coagulopathy is happening. These three together is known as the lethal triad. And they are like one activates the other and it makes it worse and vicious cycle. So basically what you need to do is you need to correct the anatomical damage. Anatomical damage is there, which has caused blood loss and which has caused hemoperitoneum. We know this, hemoperitoneum. Now bacteria and all is there, so and all that will cause peritonitis, and it'll again lead to sepsis. You know this routine. And this blood loss has led to hypovolemic shock. You have already seen it. Here. Now, here comes the concept of damage control surgery, not resuscitation. Important Viva, important MCQ, important short note, important for MB. So what do you do? The aim of this surgery, aim of this process is to combat the lethal triad. Clear? We need to correct the hypovolemia, we need to correct the hypothermia, the acidosis and the coagulopathy, which is causing all the problems. So what is the principle? Every surgery has to have a principle. What is the principle? You need to control the bleeding, and then you need to control the contamination, and then you need to go for an anatomical correction. Because even if you control momentarily, if the anatomy is not corrected, ultimately again there will be bleeding. So you have to correct the anatomy. Okay, there are many phases, but before that, MCQ question, Viva question, who gave this term? Who gave this term? Rotando, et al. Gave this term. If you remember Rotando, it's fine. You'll be able to remember Rotando. Synonymous to Ronaldo, maybe, something like that. Remember, so Rotando. So now the thing is that how do you go about it? So there are some phases. How many phases are there? I think there are 3 phases. I think some books write 4, but I think absolutely there is 3 phases. Beatty and Love says 3. I'll go with 3. So what does phase 1 is? Phase 1 is abbreviated. Please mark this word, abbreviated surgery. That means you are actually going to control the damage. So this is the processes for damage control. How do you do? How do you do this? Very simple. Resuscitation started. You do a resuscitation also. You're going to start. But the resuscitation is started right from the OT. So you take the patient who's unstable. You give him fluids. You give him blood. You permissive hypotension, crystallized, everything you give him. And then you shift him to the surgery. And since he's unstable, you cannot do a CT. You cannot do anything. Obviously, first and all, you'll see for hemoperitoneum, but that is after, not immediately you'll do. That is while doing the primary survey and all that. So we are going to do resuscitation. You start from the OT. Inside the OT only you will continue the resuscitation, and the resuscitation will go on continuing till the ICU, which is the second phase. But what do you do in this abbreviation? Very simple. What do? You go and you open up the abdomen. You open up the abdomen. What do you open up the abdomen? Over here. And then you see the liver is bleeding. What do you do in liver trauma? Liver is the most common, second most common injury, second most common organ to get injured in blunt abdominal trauma. Most common being spleen. You've read this 1,000 times. Gunshot, then intestine. So, anyways, we said road traffic, so we'll take blunt. So, liver is bleeding. Liver has lacerated, or there is contusion, and there is bleeding. So profuse bleeding. Liver is a very vascular organ, so it is bleeding. If you learn from physiology, it takes about nearly 500 to 1000 ml of the blood every minute. It takes that much amount of blood. So that needs to be corrected. So now what do? We put packs. That is the best thing. You put packs. Compression packing, you put packs and you control the bleeding. Or if there is a vessel which is bleeding, you ligate the vessel. Clear? What do you do apart from that? You put 2 drains. Make incision, take out 1 drain. Make incision, take out 1 drain. Corrugated rubber drain. Make it out. Nothing for this character. Use it. Anyways, do drain. After this, what do you do? This medial laparotomy, you do not waste time for suturing and everything. What do? You use a bag. What is the name of the bag? The bag's name is very, very important. The bag's name is Bogota bag. The bag's name is Bogota bag. What is it made up of? Opside. Now, it looks, something exotic, but nothing. It is basically the same material present in Euro bag. If nothing is there, take a Euro bag, cut it into half, put it. Even if that is also not there, you can use anything of the material of opside, you can use it. But the very good thing is it's transparent. It is transparent, so you can see what is happening. In burst abdomen also, you cannot suture, so immediately you put a Bogota bag. Anyways, this is what you do. The next is after you've done this, you go for a phase 2. Here I'm writing a short note on damage control surgery, so I should be able to understand. Phase 2. Phase 2 is ICU. ICU you are going to continue the resuscitation. Now what do? You do ABG, you take for all the blood parameters and everything you do. And then you make the patient hemodynamically stable. So you stop the bleeding source for temporarily. You do an abbreviated surgery. You send him or her to the ICU and you resuscitate and you keep the patient stable. For how long? 24 hours is very less to say. At least 48 to 72 hours you have to keep the patient stable. After 48 hours mostly, we plan for a definite surgery. And then this is known as damage correction. This is what will be asked in your exam. What is this? This is not damage control but damage correction. That means the anatomy has to be corrected. And that will give your phase 3. Post-op is phase 4. We don't want that. So phase 3. Phase 3 is this. This is damage correction. So first is phase 4 damage control. That is abbreviated surgery. The second one is ICU resuscitation. Third is damage correction. Write this 1.5 out of 4. Explain this 3 out of 4. And now if you further go on to explain that, okay, let us talk about the liver trauma. What do you do in case of a liver trauma? It's the most common organ, there is immense bleeding, you do something which is known as 4 P's. You push, you pack, you plug, and you do a Pringle. Now, MCQ, most common things come. So Pringle is the overall best. Overall best is this thing. Compression packing is best in unstable patients. Okay. What is this push? You manual compression. You do a manual compression. How do you do a manual compression if you do laparoscopic surgery? Just take a gauze piece with a laparoscope, put it, suppose there is a liver, and then this is a gallbladder. Now you've removed the gallbladder, so there is bleeding. So what do? You take a gauze piece and then you put it and you apply pressure over here. So that is again manual compressing, or if it is an open surgery, you with your hands you put gauze piece and you compress it. Acha, what is plugging? Let me talk about plugging first. You took a sink stick and Blackmore tube, okay? Sink stick and Blackmore tube is there. You know very well what is happening. Suppose there is a laceration over here from the liver. Now what do? Suppose inverted liver I've drawn, but to show actually what is happening, you put this sink stick and Blackmore tube inside and then you fill it up. As soon as you fill it up, it is going to have a tamponading effect over here and immediately the bleeding might stop. You may try all this, but the best in unstable patients is you go for packing. What is packing? You know what is packing? It is compression packing. It is compression packing, and this is, if anyone asks you in liver trauma, when is packing done? Unstable patient. This is part of which surgery? Damage control surgery. Part of damage control surgery. Now Pringle. What is Pringle? Pringle is like the chips. Pringle is basically what happens is the portal triad is there. Portal triad consists of the hepatic artery, it consists of the portal vein, and consists of the biliary ductule, so the bile duct. These are things which happens. Now where? At the hilum? No, definitely you're not at the hilum. You're not going to ligate. You're going to not ligate. You're not going to compress. With the help, you're going to compress them as it is, emerging from the free border of the which ligament? Free border of the hepatoduodenal ligament. Hepatoduodenal ligament. Okay, you read this, which is nothing but at the foramen of Winslow. At the foramen of Winslow. Now, foramen of Winslow is an epiploic foramen is the same thing. You have these things and you're going to compress it. Now, for how long? 3 to 4 times you can do. 15 minutes duration you can at a stretch. And then you have to give 2 to 3 minutes of rest. This is the way you do a Pringles maneuver. This is again a question. 3 to 4 times you will do maximum. 15 minutes, 2 to 3 times. This is again asked. Anyways, if you see hepatic arteries, let's say 20 to 25% of the liver's blood supply. 70% of blood supply head comes from the portal vein, and 5% comes from the hepatic vein. Now, if hepatic vein is bleeding, we'll come to it last. Bile duct, so it is not associated with any blood, so we are not immaterial to that. So hepatic artery and portal vein. So with a Pringle, you are getting this and this, but still there is bleeding. That means hepatic vein. Hepatic vein is the culprit. Okay. If it is bleeding, if the bleeding stops with this, so this is actually ruled out. This is actually ruled out. So you can think that either it is the cause of hepatic artery or portal vein. Now observe the hepatic artery, see for bleeding. Then if stops, then hepatic artery is the cause. Ligate it. If hepatic vein is the cause, ligate it. If portal vein is the cause, never ligate. This is again a question, MCQ Viva. Never ligate portal vein. Why? One of the major feeding vessels. The liver will die. You do, and you will also die. Liver alone, you also will die as a result of it. If you block the portal vein, always repair it. Doesn't matter how much of it is damaged, always repair it. This is what I wanted to say. Now this Pringle is very important. By the way, hepatic vein. When we're talking about hepatic vein, you have 3 hepatic veins. One is the middle hepatic vein, one is the anterior, and one is the posterior. Or superior inferior also. Now what do? There are 3 territories. Quinoid segments are divided on basis of hepatic artery and hepatic veins. So on basis of that you have on clockwise direction all the quinoid segments. So we're not going into that. Just remember the territory which individual hepatic veins are occupying in the liver, and according to that you ligate the hepatic vein which is the culprit. Okay. Fine. Now when you have done this, you should be very clear with what I'm going to see next. Now this packing and all is fine. Now, what happens is, this is what you do in liver trauma, and you definitely, when this is done, you push and pack and everything, and definitely you go for a CECT. You do for a CECT, and then you see the grade of the liver trauma. You see the grade of trauma. I'm not going to teach you the grade of the trauma over here. That is, you can read it. That the CECT, you do the grade of the trauma, and you may decide on the basis of that. If there is a general consensus, we'll come to it later. Agar grade 1 and 2 hai, then you do for observation. If it is grade 3 and grade 4, grade 3 you may prepare for surgery, and grade 4 definitely you go for a surgery intervention. The intervention is required, and intervention is required. You know, the biggest thing is, why don't we suture? Why don't we? And even angioembolization is an option over here. Angioembolization or surgery, whichever one suits. We'll come to that, but for grade 3 now, the question is that where do we, you know, why don't we suture? Why don't we suture the liver? You know, when a liver is bleeding and liver damage, it is just like a butter. Suppose this is a butter block. Suppose this is a butter block, and you try to suture it. What will happen? You will put the bite, it will enter, it will come out, and when you pull over here, what will happen is, all along with this, all the segment, suppose this is the entire thing, all the segment over here will, you know, there will be a cavity formed, and then the suture material will come out, because it is so loose. It will cut through the liver and nothing will happen. It will cause more damage to the liver rather than this. So basically, liver is not sutured like that. Now, if nothing caused, you have to go for a hepatectomy. Now, this hepatectomy is a very dangerous thing. It is generally elective procedure. You remove lobes of segment and all that. But when bleeding is not controlled. But if you have to do it as an emergency procedure when bleeding is not controlled at all, it is a very risky surgery, but you may apply that. Steps, I am not going. Segments which are removed, I am not going, because that is something which will take a lot of time. Now, next is, suppose in short, if you talk about splenic trauma, these are the most common traumas which is associated with. So when you're writing a long question, you write that, and you write the splenic trauma. But the splenic trauma, the grading you need to remember. Let's remember the grading of splenic trauma. You know, the grading is very simple. It is based on contusion. It is based on laceration. This is one of the simplest grading. If you remember spleen, you remember everything. Liver, you remember renal, everything. Okay, now abdominal traumas may. Now grading. Suppose grading here. So less than 10% is confusion. 10 to 50% is contusion. Then more than 50% is contusion. Or you have less than 1 centimeter, 1 to 3 centimeter, more than 3 centimeter. Very fine. This is 1, 2, 3. Clear? What about grade 4 or grade 5? More than 25%, not contusion, devascularization. Now, what is this devascularization? Why does this devascularization come? Because there is damage to the hilum where the pedicle is there. You are absolutely devascularizing it. And the last one is a completely shattered spleen. Completely shattered spleen. It is broken and everything. Completely devascularized. So what is happening? You are seeing there are 5 grades. Now the only difference in renal trauma comes where in grade 5 of renal trauma there is devascularization. Just I'm comparing and contrasting for your understanding. So renal trauma mein grade 5 is devascularization. Otherwise it's all fine. Now remember. So what do you do? Suppose the patient is, suppose the splenic trauma is there. Suppose you're anticipating a splenic trauma and the patient is unstable. Your patient is unstable. What do you do? Splenectomy. No looking here, there, no CECT, nothing. Go for splenectomy. If the patient is stable, take the patient up for CECT. See, in liver also, if the patient is unstable, definitely you're going to do for that PPPP. But if the patient is stable, go for CECT, grade it and then treat it accordingly. Now, why just do a blind procedure if the patient is stable? Now, CECT. Now, again in CECT, for your level, grade 1, 2 and 3, you just do observation. Grade 4 and 5, you do a splenectomy. Now, some books is splenography. Now, I believe it is something which is, can only be said but not done, because most cases it is seen, it is written in Bailey and Love. That in most cases of splenography, if you do, there is definitely an orthosplenectomy after some time. So you won't do splenography, generally do splenectomy is preferred. If both are given options, splenectomy is the answer. If only splenography is given the option, mark it as splenography. Because again, some books have different understanding of it. Now, suppose it's a very interesting understanding. Subcapsular hematoma. This is the only organ where there is subcapsular hematoma can cause. So this is again a question and understanding. It is the only organ whose trauma causing subcapsular hematoma, causing subcapsular hematoma subcapsular hematoma actually may lead to total devascularization. Because once the hematoma starts forming, there is no stopping it. It will completely devascularize the spleen. So you have to do a splenectomy. Again, a question, viva, honors question. Anyways, it might be asked. So this is what you're going to say. Now the next three is something which is beyond your prof level, but they're going to ask you. Suppose there is a contrast, you've given contrast, but the contrast blush. What is blush? That means from the hilum, the dye is leaking at a constant rate. The dye is leaking at a constant rate. If that is so, then you will do something. The hilum the vessels are together. It makes sense you do an angioembolization to block the vessels which are bleeding. And if it doesn't work, then go for a splenectomy. Do not sacrifice the spleen. A person, there is a dictum. Let me say the dictum. A person can survive without a spleen rather than with a bleeding spleen. So this bleeding spleen. So it is not a torrential hemorrhage which I am talking about. Subcapsular hematoma anyhow is going to progress. So even if there is not much hemorrhage at the time, you go for splenectomy. Grade 4, grade 5, definitely there is devascularization. You have to go for splenectomy. 1, 2, 3 you can observe for self-resolution. Contrast blush, hilum, the dye is leaking from at a constant rate from the hilum. So you can do an angioembolization because at the hilum, where the splenic pedicle, everything is there, you can actually block it. If it doesn't work, you do a splenectomy. If there is a pseudoaneurysm, which is very likely, as you've already said, sometimes what happens in even pancreatitis, a complication you've read that there might be pseudoaneurysm of the splenic artery. Anyway, so this is pseudoaneurysm of the spleen. What do you do? The first line, please remember, the first line treatment is doing an angioembolization. Do it. It'll prevent the angioembolization. It will prevent the vessel from bleeding or progressing to bleeding. Otherwise, the best treatment is, you go for splenectomy. So, indication of splenectomy is something which is different. But I'm saying splenic trauma, this is how you are going to approach against a splenic trauma. After that, you're going to just write about OPSI and what all vaccines, when it is given 2 weeks before, continue. Or sometimes there is low risk, calculate the risk. If it is low risk, and you come only when there is fever. The patient knows what antibiotics to take. The patient will be on antibiotic and come. So everything you read it from Bailey and Love. That is the portion of OPSI, which is a different short note. So this is and you just write about that at the end. Now this is what is your total answer. Can we just revise it quickly from the beginning to the end? I think it will be very good if I can revise it. Let's see. Okay, here we go. Suppose, the case was 36-year-old male presents to the ER following a road traffic accident, and you find that there is pain abdomen, patent abrasion over the abdomen, and the vitals are unstable. How do you approach? You do a resuscitation and a primary survey. You do damage control resuscitation, all the 5 points you mentioned. You do a primary survey, A, B, C, D, E, cervical spine stabilization, you do it. Mention about the dynamic fluid response therapy, how it responds, transient responders being special importance. Draw this graph. Then you do not have to write this shock, but since you just have to write the parameters, HR 114.2, 8.93, BP 3, MAP 3, almost going to 4. So basically you can say class 3 requiring blood transfusion. So this is where you can say. This is the way. So grade 3 ka, you can write all the parameters and then you compare it and you write it. Don't have to write the entire chart. Anyways, then you talk about blood transfusion. This is a lethal trial is happening in this patient. So our purpose is that is blood loss and hemoperitoneum. Write this: blood loss, hypovolemic shock, hemoperitoneum, peritoneum sepsis, peritonitis and sepsis. So you do damage control surgery. What is the principle? What is the aim? Write it. Then you are going to see what are the phases. 3 phases. First you do an abbreviated surgery. Then you do. So what is the aim? The aim was to control bleeding. The aim was to combat the lethal threat. The principle was to control the bleeding and contamination. Now you do the phases. First is the abbreviated surgery. You do a compression packing, Bogota back, take out drains. Phase 2 you send it to ICU. From resuscitation should start from the OT, continue in the ICU. After 48 hours you plan for surgery and you do a damage correction surgery. That means whatever surgery is, if the spleen was bleeding, splenectomy. If the liver was bleeding, then you go for other procedures in which you can repair the liver and all that. So the purify the portal vein, ligating the hepatic artery and all that. You go and do it. After resuscitation, this is a question. Now you may be confused. Then when to do 4Ps and when to go for a CCT? The patient has come. You are definitely, you do an EFAS, you see a hemoperitoneum. You cannot see any rupture or anything. You can see hemoperitoneum. So you don't know what is the cause. You do a meninoperatomy, you see where the bleeding was. And immediately you do 4P and stop it. Now when the patient is stable, please go for a CCT. Go for a CCT. See the grade, see where it has happened, and then you go and do the operation for spleen or liver. If pancreas renal, I'm not writing, because if it was hitting from the back, I would have talked about renal trauma. Pancreatitis and really bike handle, other features would have been there. So I'm not going to do that. So mainly liver and spleen you're going to base your answer on. If you want to write pancreas, you can. Renal, you don't need to write. Pancreas, you can. You may read it from Bailey and Love. Very short it is given. You may write it. But over here, we can talk about liver and spleen mostly. So 4Ps, we've talked about the 4Ps. Write about the 4Ps. And how do you approach, whether it is hepatic artery, portal vein or hepatic vein. Now, hepatectomy, we generally don't do. Why don't we suture? Because it is like butter. It will come out. The suture will come out, causing more trauma. Now, splenic trauma, you will need to write the grades. You write the grades according to CECT and just compare it with this renal trauma grade 5, and then you're writing the splenic trauma is unstable, you do a splenectomy. If the patient is stable, do a CCT, see the grade, observe. If 4, 1, 2, 3, if 4 and 5, splenectomy, more the splenoidopathy. Subcapsular hematoma, it will progress to revascularization, so go for splenectomy. Why? Read it later. I'm not going, because this video is only for the answer to this question. Contrast blush, hilum leaking through the dye, go for angioembolization. Doesn't work, go for splenectomy. Pseudoaneurysm, first line, angioembolization, best treatment is splenectomy again. A patient, and then you can write this dictum. A patient can survive without a spleen rather than with a bleeding spleen. And then in the end, you can write about autopsy and a post-op management and the workup, and you may write this. This is the thing you need to understand, and this is the sort of thing you need to write.